Good morning and a very warm welcome to all the listeners here today. Today on 12th February 2023 is World Epilepsy Day. We have all heard of epilepsy and we know that it's something to do with fits and some electrical impulses. But today I have here before you Dr. Anil Venkitachalam, who is an MD in medicine with a specialization in neurology. He is a senior consultant of neurology in LTMMC Medical College and also a senior visiting consultant at Nanavati Hospital, Fortis Hospital and Kokilabai Dhirubhai Ambani Hospital, Vashi, Mumbai. He has a large body of publications, books, chapters, and his area of specialization are movement disorders, deep brain stimulation surgery, and botulinum toxin therapy. He also has received many achievements and awards, specifically the UCB Young Neurologist Scholarship 2008. Please welcome Dr. Venkitachalam. Welcome, sir.
Hello, ma'am. Yeah. Hi.
Yeah. Sir, to start off right away, epilepsy is a very confusing and, for the lay person, we really don't know what it is and there's a lot of stigma related to it. I would like to understand what do we mean by a seizure?
So, a seizure is basically, a seizure is basically a condition where there are abnormal electrical impulses which are generated in the brain, as a result of which it leads to basically the dysfunctioning of the brain activity. In other words, if I have to say in a layperson's terms, a seizure is like a short circuit in the brain. You just have a shorting of the circuitry in the brain, as a result of which the patient presents with the symptoms. The patient can have loss of consciousness, patient can have the symptoms of a seizure. So, that's what we call as a seizure from the anatomical sort of terms inside the brain. Like that's what happens in a seizure inside the brain.
Then what is epilepsy? Is it the same as a seizure or is it different?
So an epilepsy is a condition where a patient gets recurrent seizures. So a seizure may be due to various reasons. For example, if the patient is an alcoholic, he might have had a seizure. Or if the patient has had low sugars, he or she might have had a seizure. Then there's a condition where people have seizures when they have fever. But in epilepsy, epilepsy is basically a disease or a syndrome where the patient gets recurrent seizures one after the other. It may not be immediately, but they get it over a period of time.
Okay, so these seizures will be recurring unless they do something to treat it. So but how can we avoid having a seizure? Is there some preventive or what are the triggers for a seizure?
Yeah, so there are lots of triggers for a seizure. We need to understand that very clearly. So number one is stress is actually a big trigger. Fever is a trigger. You have emotional triggers. Then there is like photosensitivity. Some people who are exposed to very bright lights, are actually known to have seizures. In fact, there was a famous Pokemon episode in Japan where people had seizures. This was also called as Pokemon seizures, where there was so much of like photosensitivity where children were exposed to. They had nausea, vomiting. Almost around 600 children were hospitalized after that episode. There are other triggers for a seizure like hormones, or electrolyte abnormalities, etc. Some patients have structural triggers, structural problems. Like for example, you could have a space occupying lesion or a tumor or a cyst in the brain, or you could have some infection in the brain. All this can actually trigger seizures.
Oh, so that's quite a complex set of triggers. Can we understand, like, does a seizure have some kind of phases, and how can we say, okay, this is a seizure or this is not a seizure? How can I identify a lay person is seeing? Because we have all these exaggerated film things where somebody gets a seizure on the road, then they put a chappal in his mouth, and there's some kind of, or they put a leather or something in the mouth. This is what we see in the movies, and then something trickles down from the mouth. So what is all that, and how do you identify a seizure?
Yeah, so this is actually a very good question. People always assume that seizure is what they see in the movies, where suddenly somebody has a loss of consciousness and then they bite their tongue and they have jerking, etc. We need to realize that there are various kinds of seizures. So you can have
Okay.
generalized seizures where you have loss of consciousness with the tonic-clonic movements, which are so much exaggerated in the movies. Or you can have partial seizures or focal seizures. In focal seizures, you may have just brief jerks of your hands or brief jerks of your legs. Or you have something called as complex partial seizures, where somebody is just slightly confused. They have this blank stare, they have some sort of a confusion, they have oromandibular automatisms, they have unawareness, and then it's like they snap in and they snap out.
Right.
Children have a variant of seizure known as absent seizures. So small kids, they may be writing and then suddenly they may stop writing and again they start writing. So you'll see that there are breaks in what they're doing, and these are known as absent seizures. So there are various kinds of seizures, but
Right.
in general, you need to first identify whether the patient or the individual is having generalized seizures or focal seizures. And then there are phases in a seizure. So you have a pre-ictal phase or a prodromal phase where they have, uh, a feeling of intense anxiety or uneasiness or
Right.
some abdominal discomfort, following which they have the event
Right.
where you may have the tonic-clonic movement or you have jerking, and then they become unconscious. And then after that, when they regain their consciousness, they are confused for a long period of time. So that's called as a post-ictal confusion.
Right.
During the event, the patient may have a tongue bite. The patient may also, have urinary incontinence and stool incontinence.
They can fall also, right?
They can, yeah. Usually, a lot of patients do fall when they are having a seizure.
Right.
In complex partial seizures, remember the 3 A's. They have these auras. They have these auras. Visual auras are there, or they have olfactory auras where they feel the smell of burning rubber, or they have abnormal smells. They have abnormal visual auras, or they hear abnormal sounds. Or they may have a sensory aura, following which they have automatisms like oromandibular movements, hand movements, or like repetitive behavior. And then the awareness is actually lost, for some time. So it's like auras, automatisms, and unawareness, which these patients have. And then they again become perfectly normal. So complex partial seizures are slightly more difficult to identify. Focal seizures may be slightly difficult to identify. They are the ones which are more common.
Right.
The generalized tonic-clonic seizures, which are often seen in the movies,
Yes.
or are the ones which are not so very common. But that's
easier
what
to
people
identify.
actually,
Yeah,
relate to
because
as a
it's
classical
more
seizure.
visual.
Exactly.
Yes.
Exactly.
So, what you already told us what can be the various causes of a seizure, but what can a lay person do? Let's, for example, I'm sitting in my, in my office, or I'm walking on the road and I see someone getting a seizure. I mean, then there's a crowd. But what are we supposed to do, because everybody is giving their little piece, aisa karo, vaisa karo, do this, do that. So what should a lay person do? What is the first thing that they should do?
Okay, so whenever you see a patient having a seizure, the first thing is please do not panic. That's the first thing. Second thing is please do not crowd around that patient. By crowding around the patient, you're not allowing the patient to breathe comfortably at that point of time. If the patient is wearing any clothes which are very, very sort of constricting or very tight, try to loosen the clothes.
Okay.
Do not put anything in the mouth of the patient. Do not put keys, or do not put slippers or anything, or onions, etc., because patient may actually choke during that point of time.
Yes.
That's one thing we need to
Yeah.
realize. All you have to do is let the seizure pass off. Try to move the face on one side, which we call as a lateral position, so that the tongue doesn't fall back and obstruct the airway, so you don't really choke.
Yeah.
Otherwise, you don't have to worry. If the patient has a tongue bite, that's fine.
Yeah.
If the patient has, if the patient, in fact, if you're trying to stop the seizure by holding the patient, you may do more harm. The patient may have a spine injury or joint injury.
Okay.
They may
So
have
you
a
should
fracture.
let the seizure pass.
Let the seizure pass off.
Okay.
Once the patient regains consciousness, wait for the patient to, be a little bit stable. do not feed the patient anything immediately, because the patient
Right,
again
water or
would choke.
something. Yeah, some people tend
Again,
to
you
say.
would choke. A lot of times these patients vomit after a seizure. So again, they may aspirate.
Yes.
So you have to prevent that, and then take the patient immediately to the closest medical center where you can
Yes.
seek medical help.
To the emergency of
Yeah,
the closest. Yeah,
you should actually
hospital.
take the patient to an emergency so that they can
Right.
be appropriately treated.
Right, by the.
I usually say do not give any first aid. Do not try to stop the seizure.
Yeah.
Because that's the worst thing you can actually do.
Yes, so I think this is very important for us, the lay person, that okay, let the seizure happen, lay them on the side, wait for the seizure, if I'm right to summarize what you're saying, wait for the seizure to pass, and then carry the patient to the nearest hospital,
Exactly.
to the SOS emergency, so that he can have proper medical treatment.
Exactly.
Yeah, wonderful. So now that's something I really learned
And
today.
we also need to realize that a seizure is usually very brief. It is not something which happens for a long period of time.
Yes, yes.
It usually lasts less than a minute if we look at it, or maximum up
Yes.
to 2 minutes.
Yes, yes. It's
So
a very brief episode.
it's actually a brief event. The entire event, the pre-ictal phase, the ictal phase, and the post-ictal phase lasts for a long period of time.
Yeah.
But the seizure itself is very brief. So you don't have to do anything,
Yes,
in a hurry during that period of time.
Yes. The only thing is people get worried if they are driving, they can fall down. So, do you have any do's and don'ts for epileptic patients that they should be advised?
See, if an epilepsy patient is adequately treated and the seizures are well controlled, they can lead a near normal life. In fact, they can lead a normal life.
Yes.
We have numerous instances of people who have epilepsy and they have gone on to lead a normal life, have highly functioning careers, do very well in their life. Yeah, there are certain restrictions you would not do. You would not work around water bodies, especially if you are unsupervised. Go swimming because you could have a seizure. Driving again is a problem, especially
It's
if you
not
are
advisable.
working as a driver. Again, it's a big problem
Yes.
because you may have, you may have shift duties. Sleep deprivation is a big trigger for a seizure. We need to realize
sleep
that.
deprivation,
Yeah. So driving again is a problem. Again, these patients cannot do high intensity work like flying aeroplanes,
Yes.
or working in the army,
Or
the
merchant
fire
navy.
brigade, or the fire brigade, etc.
Right.
So these are again occupations which are
Be avoided.
hazardous and which are to be avoided. Again, if you're planning to go on a trek unsupervised or climb mountains, you need to be
Yes.
careful because again there are triggers. When you're climbing mountains, hypoxia can be a trigger.
Yes,
Lack
yes.
of oxygen can be a
Yes,
trigger. You need to be
yes.
careful about these things.
Yes.
Intense exercise sometimes can trigger seizures. We need to realize that.
Okay.
So these are some things which people need to understand. Otherwise, you can lead a normal life.
How does the doctor choose the epileptic seizure medications, or do parents get, patients or their guardians get choices? Do these medications have long-term side effects or even short-term side effects which affect your productivity and functionality? Which is, I think, because lot of compliance issues happen with these types of neurological medications, because it may be treating my epilepsy, but otherwise it's causing other dysfunctionalities. What would you suggest, and what do you think should be the solution for this?
Yeah,
And what are the type of medications they can have?
Yeah, this is actually a very good question, and we're often asked. Patients are very resistant to starting medications. We have to sit down with the patients and we have to counsel them for a period of time and see what they would like to have. We need to remember that patients who have epilepsy will need anti-seizure medications for a good deal of time, for a significant amount of time, at least a minimum period of 2 years, may go up to 5 years. Some people may have to take it lifelong. So
yes, that's what I
these are
heard. It
three
is
things.
lifetime. And as a human being, when you are told that you have to take something lifetime, like if you're talking about diabetes or BP or thyroid, all of us resist. We want it to be like something temporary and go away. So that can be very, disheartening, I would say.
Yes, it is. So what I usually tell my patients is, let's start off with the medication, see if your seizures are under control, and then we taper off the medications and then see if you're getting a recurrence in your seizures. The choice of the drug is totally dependent on the doctor, depending upon the patient profile. So some other drugs may cause weight gain, some other drugs are contraindicated in women who are childbearing, some other drugs cause hair fall. So in general, there are generations of these drugs. We have the older generation drugs and we have the newer generation drugs and we have the latest generation drugs. So there have been phases. Some of the older generation drugs are available since the 1930s, 1940s. You know, the ones are like phenobarbital and like phenytoin, sodium valproate is available since the 1970s, 1980s.
Yes.
And we've had the newer drugs like levetiracetam, topiramate, we have brivaracetam, lacosamide.
Right.
In fact, a lot of new drugs are actually coming out in the market right now.
Yes.
So we need to sit down with the patient. We need to first classify what is the epilepsy that they have, and then accordingly they need to be started on the medication. You need to choose the drug appropriately. For example, you know, some of the drugs may be highly sedating, and if the individual is a student, you know, who's actually giving their 12th exam or the engineering exam, it may be very difficult. So we have to choose something which is having a lesser sedation. Somebody has significant obesity or someone is overweight, then we would avoid certain drugs and we would give other set of drugs. So we need to choose the drug carefully. Also, the dosing of the drug needs to be chosen depending upon the compliance. You know, some patients are like, we would like to have the medication only once or twice a day.
Right, in the night
they
only,
may not want to take multiple drugs or multiple. They may not want to take the medication like multiple
times in a day. To remember it is difficult.
That's one thing.
So do you have sustained release tablets then? For
yes,
such
it is available. Sustained release tablets are available. But we need to slowly titrate the medication to the dose and then look for the side effects.
And also I wanted to know, injections are also available in form of injections?
So injections are available and injections are usually used on an emergency basis. Again, when you have a seizure and then you are admitted to the hospital, at that point of time the injections are used. But in general it's oral medications and these are safe. Another important point we need to remember is the cost issues. You know, a lot of patients, the newer drugs are more costly.
Yes.
So again, the cost of therapy significantly increases. So patients again are like, we have to see whether they are ready to spend that amount of money, you know, because it could cost, you know, a significant amount of money,
and it's
at least for somebody
term.
In the long term. You know, it's like anywhere between like 2,000-3,000 rupees per month when you're actually taking, you know, the newer medications.
What happens when if a woman or a girl gets epilepsy? Does it get connected with her monthly period cycle, and what happens when she gets pregnant? Will it not affect the fetus? I mean, what are the things to be looked at when such a thing happens? Because very often the women, they hide it, they get married, and then afterwards, you know, everything comes out. But then what can be done? So
this is a particular challenge in our practice. Yes, I mean, I do agree. So there is a subgroup of women who are known to have what we call as a hormone-related epilepsy, so-called as a catamenial epilepsy, where every time during the menses or before the menses, they actually have seizures. And that's purely hormonal. You know, in such situations, we usually give them an anti-seizure medication just before their periods. And then they're able to have a good control of their seizures, and once they attain like menopause, you know, they usually you know, outgrow the seizures. They don't have any seizures. There's another group of women where hormones trigger the epilepsy. That's known to occur. Yes, it's a challenge because some of the drugs are contraindicated in women, especially if they are of the childbearing age, like sodium valproate, which is a very commonly used drug, causes weight gain, causes polycystic ovary, causes hirsutism. So that's one problem. Similarly, we cannot use most of the anti-epileptic drugs in pregnancy except a drug called as levetiracetam and lamotrigine. I mean, these are two drugs which you could use. So you need to be careful, you need to select it well. in general, I tell the patients that don't try and hide it, because people would be able to find out at some
Yes.
point of time if you
Yes.
hide it. So it's better to be honest. And again, epilepsy is not a psychiatric disease; it's a neurological problem.
Right.
Such patients can be easily treated. Most of them have a very good control of their seizures with medication.
And they can lead a normal functional life.
Absolutely normal life.
They can get pregnant and have children
Yes,
also.
absolutely.
You have seen many mothers.
Almost, except the ones who are highly refractory epilepsies, it's usually a challenge. The ones who are very well controlled, there is no challenge per se.
They are able to lead
a normal life. They are able to have, children. They have a normal childbirth.
Oh,
They
that's
are
good to
even
hear.
able to lactate normally.
Oh, wow.
They are
Yeah,
able to
that's
breastfeed
wonderful.
their children.
Yeah.
So it's not much of a problem at all.
Okay, the breastfeeding will not, the medication will not.
So again, you
restrict
have
the
to sit down
children.
with the neurologist and choose the drug. But again, the
Okay.
drugs are, we do have safe drugs which are available, and you can safely administer them during breastfeeding.
Taking off from the point you mentioned that except those who have refractory epilepsy, what exactly is refractory epilepsy?
See,
and
around
how is it?
15-20% of patients do not respond to multiple anti-seizure medications. Usually
They still
we
have
say-
seizures.
Yeah, they
Okay.
continue to have seizures despite very good compliance.
Yes.
So if you have recurrent seizures despite being on 3 or more anti-epileptic drugs, then it's
Yes.
known as refractory epilepsy.
Okay.
These patients usually have some structural pathology.
Okay.
Sometimes they may have a perinatal insult. So that means when they were in the uterus of their mother,
Right.
they might have had a sort of a perinatal insult, or they might have had some brain injury like hypoxia at the time
Yes,
of
at the
childbirth.
time of childbirth,
Or
which affected something in the
yes,
structure
or
of the brain.
some of them have something called as a temporal lobe epilepsy, where the hippocampus, which is a small part of the brain responsible for your memory and responsible for the brain functioning, actually atrophies, it shrinks.
Oh.
And that causes recurrent seizures. That's a
Okay.
highly epileptogenic area actually of the brain. So that
But you can't
is
do any
dysfunctional.
surgery there, I suppose.
Yes, you can do hippocampal, you can do surgery for hippocampal sclerosis,
Oh.
but you need to again select the patient carefully. There is something called as a pre-surgical evaluation,
Okay.
where you admit these patients, do a video EEG recording. You try to taper off the anti-seizure medications, do a video EEG recording, see if the seizures are actually occurring. Try to localize the part of the brain from where the seizures are coming.
So that
Then-
can work.
Yes, it can work.
Oh,
You
wow.
sit down with the neurosurgeon, sit down with the radiologist and the neurologist. You plan the surgery and see if they are very good candidates. But again, you need to do rigorous screening for these
Yes,
patients.
yes.
It's not something where you just go and remove a part of the brain. It's not like
Yeah,
that.
I know. It doesn't get as easy as that because you remove some good parts also.
Exactly.
So that would be very
So
risky.
this is more of a lesion, this is more where you remove a part of the brain. Then there are lesioning surgeries.
Lesions.
There are further advancements also available now. The latest generation surgeries like vagal nerve stimulation is there.
Oh, wow.
So you have a
What
nerve
is that?
stimulator. So you basically implant a nerve stimulator, and whenever the patient has a seizure, is about to have a seizure, you just need to trigger it, and then it can
It
abruptly
can absorb
stop.
the electricity or
It
something
can actually
like that.
stop the seizure.
Oh,
It can
it
actually
stop.
terminate the seizure. It acts via the vagal nerve.
Mm.
There is also
Wow.
a newer surgery called as deep brain stimulation, which is coming up.
Mm.
So where you implant what we call as pacemakers in the brain to try and
Yeah, we've heard
stop
of
the seizure.
pacemakers in the heart, but in the brain, wow.
Yeah, there are pacemakers in the brain which are used mainly for Parkinson's disease, but now they are being tried out even for epilepsy.
Well,
to
that's
control.
very interesting because there was a huge controversy on social media recently about this Neuralink, which Elon Musk has, they've implanted the first chip in the brain of a human being.
Yeah,
And
but
there were ethical questions. Of course, this would be different, I suppose.
this is just what he's doing is slightly a modification of what is already being done. If you look at it,
Oh, really?
DBS surgery has been around since the 1990s
Oh, wow. But
for
it's...
Parkinson's disease,
Mhm.
and it's FDA approved
Wow.
surgery for Parkinson's disease.
disease. Okay.
I think I'm not the right person to really comment on Elon Musk, but what he is actually doing is actually gathering data. So that's got something
That's different.
Different. Here,
He's
this
gathering
is purely
data of the brain through the chip or
exactly.
something
So
like that.
this is purely for medical reasons, and
it's a therapy.
and it's got wonderful results. So in Parkinson's disease, in tremor, in some psychiatric problems like OCD, it's got very good results.
Oh wow!
So yes, so I mean,
because psychologically, I'd be afraid to insert something in my brain. If you're talking about VNS or DBS, you're inserting something in my brain. So,
but these are used as a last option. These are not the first option. When everything fails, then this becomes an option.
Yeah, when it is like treatment-resistant epilepsy
absolutely.
or something like that. And I wanted to know, there is so much knowledge gap, which you've told me so many things which I didn't know earlier. In epilepsy, there's so much of knowledge gap, and there's an importance of information. How can we actually, today you and I are speaking here on Acharya 90 FM, and the more people who hear it will benefit. But what do you think should be done for, not medical education of patients? Do you think enough is being done, or we should be doing more? What do you suggest?
Yeah, I don't think enough is being done. A lot of epilepsy patients still hide behind the closet. They don't want to disclose the disease because still there is this stigma in India that it's a psychiatric disease or it's a psychiatric illness. Now people actually hide it. And if you look at it in the villages, there are these cultural practices where they think evil spirits have entered the body, and they use a lot of people use things like black magic and other things.
Is it still happening now
Yes,
in
it
India?
does. You would be surprised.
Oh
it
my
still
God.
does. Yeah.
I
mean, living in an urban center, we don't really
don't come to know about
we
it.
don't actually come to know, but people still believe in this black magic and evil spirits, and they still seek the help of religious practices, and there's a lot of I mean, there are a lot of myths with respect to it. I don't think we're giving enough information. A lot of children have epilepsy. Parents are in denial, for these children. And you can identify these children with epilepsy. You can identify them. They might have had a seizure. And then they say, they attribute it to fever, and they attribute it to dehydration
and so many other things. Yeah.
Similarly, women who have epilepsy, they say that, unko just chakkar aake gir gayi.
Yeah. They don't want to admit the real thing.
People don't want to.
Khana nahi khaya tha.
Exactly. So these are some of the common things we often face, and they're not really ready to believe. We also need to realize that a lot of tests are not foolproof. The MRIs may be normal, the EEGs may be normal.
Yes.
And then when they come back to the doctor, they tell us, see, we told you so, the reports are normal. It's not so. So it becomes very difficult.
Also, it would be during the seizure, the report would be different, just before or after. And then it probably normalizes again.
Exactly.
So, is it very difficult to diagnose then?
So, the most important is an accurate clinical history, an eyewitness account, a clinical history. And then afterwards we get a set of blood tests done to rule out electrolyte abnormalities, calcium abnormalities, sodium abnormalities, etc. Look at the thyroid status, the sugar status, etc. We get an MRI done to rule out a space occupying lesion or some cysts in the brain. Very commonly in our country we see these cysts, of the worms, basically the neurocysticercosis, which is there in the brain. So the eggs are there in the brain, that causes it.
Oh my God.
Very often, tuberculosis in the brain presents with seizures. You have tuberculomas in the brain which causes seizures. So you need
those
to get
can be curable also, maybe.
Most of them are curable, so they do well.
Treatable,
they are treatable and they do well on medications. Most of them, yes, are. The other challenge is that then we get an EEG done for these patients, and then we sit down with the family, and then most often from our history and other examination, we're able to find out whether the patient has epilepsy or not, and we can then accordingly treat it.
I would like to know, out of 100 people, what is the incidence of epilepsy world over? Is it more in certain regions of the world, or is it's not, it's agnostic? I mean, it's not related to sex, age, or any geographical or people eating a particular type of food, like what percent of the population, is it 0.2 does get epilepsy? Do we have any data about it?
So the data from the Asian countries, the Indian, from India, the Asian countries, etc., we have, it's not really very good if you look at it. Most of the data available is actually Western data from high yield centers of excellence. You have the Mayo Clinic data, the Cleveland Clinic data.
So there, everybody is going there and declaring that they have epilepsy. So the hidden data doesn't come.
Exactly. Whereas if you look at the Asian countries, you look at the poorer countries, the African countries, etc. A lot of data is not available. And I think it's because it's not a reportable disease.
Yes, it's not reportable.
It's not a reportable
It's not
disease.
like how when we talk about like World Health Organization, they're talking about diseases like say leprosy or polio or even certain
polio is actually an example of where everything is recorded and reported. So we've had very good success with,
even tuberculosis I find very surprising we don't have success, though it's a communicable disease. So epilepsy is a NCD. So in NCD also now that kind of reporting should happen.
But in general it's less than 5%.
It's less than 5%.
It should be around 2%.
2% of the population.
1 to 2%.
But that's still quite a bit. 1 in 100 people is having epilepsy. So that's not a small amount. So doctor, thank you so much. What message would you like to give our audience on World Epilepsy Day about epilepsy?
So my final word is that I would like to tell our audience that first of all, it's important to identify whether somebody is having a seizure. And if someone has had a seizure, please go to your doctor. I would like to say that epilepsy is a treatable disease. You can treat it. You can sit down with your doctor. There are very good medications available. In fact, if you leave it untreated, it could be fatal, And it's very important to realize that please do not ignore your seizures. You may be crossing the road, you may be driving the car, you may be alone. And if you're not treated and you get a big seizure, it could be life-threatening for you. So that's one thing we need to realize. So since it's a treatable disease, it can be easily, it can be easily managed. And do not fall prey to myths about the disease. That's the only thing that I can say.
Thank you, Dr. Venkitachalam, for this wonderful, detailing and explanation of epilepsy. I think my eyes have opened a lot today.
Thank you, ma'am.
And I think next time if I happen to see anybody with a seizure, I know what to do. And I think there's a lot of hope with all these new therapies, and I think most of the patients can lead a normal life and, take treatments, be compliant, and also avoid stigma. Thank you very much.
Thank you, ma'am.